Bismillah wa salatu wassalam ala Rasulillah. Welcome to Level 2 lecture in breast cancer diagnostic and therapeutic approach. And this lecture directed to residents who are preparing for board exam, whatever the board exam is. Our learning outcomes: classify breast adenocarcinoma, perform a comprehensive approach for breast cancer patients according to the stage of the disease, demonstrate understanding of surgeon's role in a multidisciplinary team for the treatment of breast cancer. To reach our learning outcomes, we have to go through these contents: breast adenocarcinoma classification, strategy, how to manage such patient, diagnosis, staging, treatment according to the stage, treatment of breast cancer and pregnancy. Once we are talking about breast cancer, everybody will understand we are talking about adenocarcinoma of the breast. Of course, breast cancer has other type of malignancy, but we are not here to talk about any of these types. Just we will concentrate on the adenocarcinoma, which originate from the glandular tissue itself. For example, the lymphoma, fibrosarcoma, or angiosarcoma of the breast. These additional cancers, they are very rare. We will not talk about them in this lecture. So the classification of breast cancer, we can classify the breast cancer according to molecular features. Let's start from depth. So we will start from the molecular feature. We have luminal type A, luminal type B, basal, and basoluminal. We'll talk about all of them in details. We can classify breast cancer also according to invasion, whether it is non-invasive or invasive. And we can classify it according to morphology, like not otherwise specific, not otherwise specified NOS, which represent 80%, and it is invasive ductal carcinoma, or specific like lobular, medullary, mucinous, papillary, and tubular. And we have to mention here that the specific have better prognosis than the not otherwise specified NOS, which represent 80%, actually more than the specific. According to cause, it can be sporadic or hereditary. Here we can see the structure of the breast. And if we concentrate here, we will see the terminal ductolobular unit, which is the functional unit of the breast. If we take one of the acini or duct here, we'll find that the duct or the acini consist of first basement membrane, myoepithelial cells, and we have luminal cells. Also between these cells, maybe you will find, if you look under the microscope, one of the progenitor cells. Cancer can originate from any of these cells. So any of these cells can have malignant changes. And according to that, we can classify the breast cancer according to the molecular subtypes. So for this, we have three main types of malignancy, a subgroup according to the molecular subtypes. We have luminal, which can be divided into luminal A and luminal B. And this type of cells represent around 40% of the malignant breast. Regarding the luminal A, the luminal B represent around 20%. So together they represent 60%, which is the most common type of the breast adenocarcinoma subtype. The features of these cells: they are hormonal receptor positive. So you'll find ER and PR positive, estrogen and progesterone receptor positive. Usually they are low grade and it has very good prognosis and they respond to endocrine therapy. The second type, which is basoluminal, it comes from the progenitor cell, or it can come from the cells which is not maturely being luminal or basal. So the basoluminal will have some features of the basal and some features of the luminal, so we call it basoluminal. These types, it has specific features which is HER2 receptor positive, and this is represent around 15% of the malignancy of the breast, and it is in between regarding the grade of the tumor, and it is in between regarding the prognosis, and it responds to the trastuzumab and slightly to chemotherapy. The basal type is triple negative, which is coming from the myoepithelial cells. Triple negative, ER/PR HER2 negative, represent around 20%. It is very high grade tumor under the microscope, and the cell differentiation will be poor, so poorly differentiated cancer, and will have poor prognosis but will respond very nicely to the chemotherapy. So as we see here, all of the breast cancer originate from the terminal ductal unit, and terminal ductal unit has acini and has duct. There is some confusion regarding lobular or ductal. Ductal means coming from the duct and lobular coming from the acini, and this is wrong. Usually ductal or lobular, it can come from the acini and it can come from the duct itself. So it is according to the features under the microscope. After we know the cancer cell phenotype and the subtypes according to the receptors and according to the molecular features of the cell, let us go to the histological features or histological subtypes. If the malignant cells cross the basement membrane, we call it invasive cancer. If it doesn't cross the basement membrane, we call it pre-invasive or non-invasive. So in non-invasive, we have ductal carcinoma in situ and lobular carcinoma in situ. The ductal carcinoma in situ is more common, and we have also in the invasive, we have ductal and lobular as invasive ductal carcinoma or invasive lobular carcinoma, and the invasive cancer is more and ductal is more. So invasive ductal carcinoma is the most prominent one, as we said in the previous classification, as we said in the previous lecture, as we said in the previous slide. The last type of classification according to the cause. So let us take the sporadic. The sporadic represent around 85% of breast cancer. Affect mainly postmenopausal ladies more than premenopausal ladies. The most common molecular subtype in sporadic cancer is ER/PR positive, that's mean luminal type. The most common gene mutation associated with the sporadic breast cancer is P53 gene mutation. But as we said, it is sporadic, so it means that the mutation will be in the somatic chromosomes and it is not in the germline. So we don't have germline mutation, we have here somatic mutation, So it doesn't go to generations. That's why if the patient having family history of breast cancer with her first degree relative and it came to her postmenopausal, it doesn't mean that it is positive family history for her daughter or for her first relative. Let's continue talking about sporadic. P53 gene is a tumor suppressor gene and is located on chromosome 17, P13. And actually the name, it comes from that it is a protein which is P53. 53 is the weight of the protein, 53 kilodalton. The function of P53 gene is formation of P53 protein. The later arrests the cell cycle at G1 phase if there is DNA damage. So the cell cannot replicate more. So because if it replicate more, it may give rise to tumor because there is some DNA damage. So the protein 53 will arrest the cell with any DNA damage. The mutation of the P53 gene lead to abnormal P53 protein and allow the cell to continue division with abnormal DNA and subsequently growth of malignant cells. Now we'll go back to hereditary, which represent 15% of breast cancer cases, mainly affects younger patient comparing to sporadic type. That's why if the patient having her first relative got malignancy in the premenopausal will increase the risk that this patient maybe she has hereditary breast cancer. The most common molecular subtype is the HER2 positive basoluminal, and breast cancer gene mutation 1 and 2 are associated with hereditary breast cancer, and they are the most. Breast cancer gene mutation 1 and 2, BRCA1 and BRCA2 genes are associated with hereditary breast cancer. Both are tumor suppressors gene. They are important for double strand repair. Mutation in any of them leads to loss of their functions and replication of DNA damaged cells, result in subsequent growth of malignant cells after several generations in the same patient. Both genes are inherited in autosomal dominant manner. BRCA1 located in chromosome 17. Mutation in this gene increases the risk of breast and ovarian cancer. BRCA2 located in chromosome 13. Mutation in this gene increases the risk of male breast cancer, cancer prostate, and pancreatic cancer. So if I have a patient with the breast lump, and this is the most common presentation of breast cancer, or she has mastalgia, or she has any complaint regarding the breast which increase the suspicion of malignancy, because we'll not go through the clinical features of malignancies as this lecture presented to the resident. So you can go to lecture level 1, which will take the strategy in more details regarding the history taking and the presenting symptoms and other things. So first, you will diagnose the patient. And once you diagnose the patient with cancer, you have to stage the patient, and then you will start your treatment. So the diagnosis will depend on the clinical, radiology, and biopsy. The clinical include history and physical examination and risk assessment. Radiology, mammogram, ultrasound, and MRI. Biopsy include core needle biopsy, whether it is bedside or ultrasound guided, stereotactic, or MRI guided biopsy. This is which we call it triple assessment. So this is just summary of what we have said, that if the patient presented with any of the symptoms that increase the suspicion of malignancy, we'll go to mammographic and ultrasound evaluation as radiology or MRI if we need it, and then we'll go through our triple assessment to diagnose the patient. Once the patient diagnosed with the cancer, it means that this patient cannot be treated by one person. This patient should go to multidisciplinary team, and the patient will be seen in a combined clinic. This combined clinic consists of clinical oncologist, surgeon, and radiotherapist at least. Plastic surgeon can be involved. The team will look at the patient and will give her staging regarding her tumor size and her lymph node as clinical staging. And then the team will decide which type of investigation will be taken to look for metastasis. So here, as we can see, T means tumor, this T classification. T1 means the tumor is less than 2 centimeter. T2, it means that the tumor size is between 2 to 5. If the tumor size is more than 5, it is T3. And if the tumor extends to the skin or chest wall, we call it T4. But there is sub-classification of the T4. So this subclassification of T4A, tumor invading the chest wall. And here we have to clarify some confusion regarding the T4A. Most of people, they consider that if the tumor reached the pectoralis major, we call it T4A. No. If it involved the chest wall, we call it T4A. Otherwise, it is still T4. If it is attached to the skin. If it is not attached to the skin or to the chest wall, we call it T3. T4B, tumor invading the skin, including beady orange, we call it T4B. If the tumor invade the skin and the chest wall, we call it T4C. And T4D for inflammatory breast cancer. The lymph node, N0, there is no lymph node. N1, ipsilateral movable axillary lymph node. N2, metastasis to ipsilateral fixed axillary or internal mammary lymph nodes. And N3, metastasis to infraclavicular, supraclavicular lymph node, or to axillary and internal mammary lymph nodes. You will find something which we missed here is TIS, which is carcinoma in situ, and TX. TX, that means the tumor cannot be assessed. And what are the example of this? The example of this, once a patient presented to me in the clinic while she has undergone incisional biopsy, which has taken part of this tumor. So the part of this tumor which is there, I don't know how much and how much left. So I cannot assess the tumor here. And TX tumor, it means that cannot be assessed, and the patient will be treated like patient who is in tumor in the maximum T, because I don't know. M for metastasis, M0 if there is no metastasis, M1 is for distant metastasis. After the clinical T and M classification of the patient, especially the T and N, will direct the team to give the best option and the cost-effective option for the metastatic workup. If the patient in very early breast cancer, T1, 2, and N0, then we'll do for the patient chest X-ray and ultrasound abdomen. And we'll add bone profile and LFT. If the bone profile shows that there is high calcium or high alkaline phosphatase, or the patient in the history having bone pain, then those patients will go for bone scan. Otherwise, in early breast cancer, we don't need bone scan and CT scan. CT scan will be included in the very early breast cancer if the patient having abnormal LFT or she has history of pulmonary symptoms. So it will suspect some metastatic to some lung metastasis. If the patient in advanced stage more than T2 or positive lymph node, the patient should have CT chest, abdomen and pelvis, bone scan, bone profile, and LFT also. So according to TNM classification, then you will take the patient into staging. So is this early breast cancer, locally advanced breast cancer, or metastatic breast cancer? So this is very easy to be memorized. If it is less than T2 and less than N1, it means that it is early breast cancer. If there is metastasis, it is stage 4. Between this and that, stage 3, which is locally advanced breast cancer. It is very easy. You don't need to memorize this. Just think about it. If the patient having T2, N1 and less, this is early breast cancer. If the patient having metastasis, this is stage 4. And this metastatic breast cancer. Between those, we have the locally advanced breast cancer. And it's very, very easy to memorize them. After you stage the patient will go back to multidisciplinary team, the tumor board now, not the clinic. So the board will sit together and will take one decision regarding this patient. Is this patient early breast cancer, and can this patient for new adjuvant chemotherapy, this patient for surgery, or patient for any of the or palliative chemotherapy, or whatever the decision will be taken according to the result of the investigation and according to the staging, complete staging. So if I have a patient with ductal carcinoma in situ, the commonest presentation of the DCIS is microcalcification in screening programs countries. In non-screening programs countries, most common presentation is bloody nipple discharge and lump. So if it is microcalcification and it is not palpable and is very small, localized, this is according to localization of the microcalcification or the lump. This will guide us for the treatment. So the treatment for DCIS, it depends, either it is diffused. If it is diffused, then we'll do mastectomy and sentinel lymph node biopsy. And why shall we do sentinel lymph node biopsy while it is DCIS? Because upgrading of the DCIS reach in some studies more than 50% of cases. they come with invasive, while the true cut shows only DCIS. At the same time, if I plan the patient for mastectomy, then if I find invasive cancer, how can I do the sentinel lymph node while I don't have a breast at all? So better to do sentinel lymph node from the beginning. In cases of localized disease, I have to do lumpectomy with 2 millimeter pathological free margins. So intraoperatively, I have to keep 1 centimeter macroscopic margin by my finger just to avoid any positive margin after lumpectomy. After that, all of those patients, they will go for radiation. So any patient underwent lumpectomy for localized DCIS should go for radiation therapy of the breast to decrease the recurrence. At the same time, if this DCIS ER, PR positive, then those patients will take hormonal therapy. Early breast cancer. This is the timeline of the patient who present with early breast cancer, and the treatment will be as follows. First, the patient will undergo surgery, then will take adjuvant systemic therapy, and the patient will go for radiation according to the indications. If the radiation indicated, the patient will go for radiation. First, we'll discuss the type of surgeries. Either mastectomy and axillary management. If it includes the axillary lymph node dissection, then we call the procedure modified radical mastectomy. Or the patient can go for breast conserving surgery, and we will go through the indications and contraindications, which means lumpectomy and axillary management. The lumpectomy should done with free margin, at least 1 centimeter macroscopic in the OR. So the result which we will wait for from histopathology, free margin, whatever the distance. So as long as there is no tumor in the margin, it means effective surgery. And the adjuvant systemic therapy, it consists of chemotherapy and trastuzumab is indicated in patient with HER2 positive, which is basoluminal, and will introduce the trastuzumab with the chemotherapy. For a patient with ER/PR positive, we'll give them the hormonal therapy after they finish the systemic therapy with chemotherapy and trastuzumab, and the patient will have also after that radiation. BCS, as we said, it is lumpectomy with free margin plus minus systemic therapy according to indication. We will know the indication of systemic therapy plus radiation. Radiation is mandatory in any patient who had BCS, whether it is for early breast cancer or for DCIS, as we mentioned in the DCIS treatment. According to all studies, especially NSABP 04 and 06, especially 06, it shows that provide the free survival distance disease equivalent to mastectomy. There is low rate of recurrence in the treated breast with patient who they undergo radiation therapy. So, without radiation therapy, the recurrence will be high. But with radiation therapy, it will decrease the recurrence by 40%. So, the recurrence is equivalent to mastectomy if we add radiation therapy. Cosmetically acceptable breast also. So, these are the things which make breast conserving surgery one of the options of the treatment of the breast cancer, of the early breast cancer. What are contraindications for breast conserving surgery? Active connective tissue diseases involving the skin, especially scleroderma and lupus. And why is this? Because those patients cannot receive radiation therapy. So any contraindication for radiation therapy in the patient is contraindication for breast conserving surgery, because one of the essential component of the breast conserving surgery is radiation therapy. If the tumor is more than 20% of the breast size, then if you do partial mastectomy for the patient, the breast volume will be very small and it will be disfigured breast. So the patient cannot undergo breast conserving surgery. Focally positive margin, and we mean by that you can go twice. If, for example, I have a patient and I took her for breast conserving surgery, then I did for her lumpectomy, and the histopathologist says that she has positive margin, I can go back again and take that positive margin for twice. If I cannot achieve negative margin, I can now say this patient is not for breast conserving surgery, while it is retrospectively, so this patient will go for mastectomy. Women less than 35 old or premenopausal women with a known BRCA1 and BRCA2 mutation, because they have very high incidence of recurrence, and this is a relative contraindication for breast conserving surgery. The absolute contraindications for breast conserving surgery: previous history of radiation to the chest or breast, radiation required during a pregnancy, diffuse malignant appearing microcalcifications. So the patient, you will leave a focus of malignancy there. Inability to achieve negative margin due to widespread disease. There are actually some confusion regarding the incision. Usually most of the people, they think that the breast Langer's line is like that. And this is really the direction of the Langer's line of the breast when the patient in anatomical position while the patient is standing. But lines of maximum resting skin tension in the breast, which we call it dynamic lines of Kreisel, it will be different. And if you do like this, maybe this will end up with non-cosmetic. And at the same time, it will be very difficult for you to go back and to take the negative margin in these patients. So the recommended incision is like this, following the lines of maximum resting skin tension in the breast, except at 6 o'clock. We prefer to be radial, like that. So, why is that? Because if you do transverse incision in this area, this will end up with disfiguring of the breast by attaching of the remnant skin after lumpectomy to the chest wall, and will make the nipple areola complex to pointed downward and inferiorly. That's why only 6 o'clock will do radial. Other than 6 o'clock, we can do them as transverse incision. Once you take the lump out, you have to put markers for the histopathologist, because once he take it out, he will ink it with different color, and he will put it under the microscope to see if any of these margins are involved with the tumor. So for example, if this area is the area where you put the single short superior, and the histopathologist find that it is without free margin, so you'll go back to the patient only to the superior area of the cavity of the lump to take the margin to make it free. Early breast cancer mastectomy. Indications of mastectomy: large tumor, more than 20% of the breast volume, multicentric disease, local recurrence if the patient had previous lumpectomy and radiation and the patient come back with recurrence, I have to do for her mastectomy now. If the cancer in a male patient, breast cancer plus high risk factors for breast cancer, and if the patient doesn't want lumpectomy. So this is the incision of the mastectomy, and you will go for axillary dissection if it is indicated, and we will talk about the indication of axillary dissection. We have to mention here very important thing regarding the incision. It is preferred to be 1 to 2 centimeters away from the nipple areola complex, so you can make sure that you have taken all breast tissue out, and you will do excision following the fascia of the breast, not the surface anatomy of the breast. So we'll go up to the clavicle here in the superior part. In the lateral part, you will go to the latissimus dorsi, inferiorly to the rectus sheath, laterally to the sternum, and you will take all of the breast from the pectoralis major, including the pectoralis major covering fascia, which is the deep pectoral fascia, to ensure that you didn't leave any breast tissue behind your mastectomy. What about lymph node management? Are all patients with breast cancer should go for axillary dissection? Answer is no. We have to mention that the axillary lymph node has a specific approach. So I have to examine the patient clinically and by radiology. If I have no suspicious lymph node by clinical or radiology, I will go for sentinel lymph node biopsy. This is especially in early breast cancer. If I have suspicious clinical or radiological lymph node, I have to do FNAC from this lymph node. If it is negative, I will go for sentinel lymph node biopsy. If it is positive, I will go for axillary dissection. Actually, here we have to mention something which is very, very important, that not all enlarged lymph nodes are positive for malignancy. And at the same time, not all impalpable lymph nodes are negative for malignancy. That's why we have to do the lymph node according to this approach. Now, we finished the surgical approach for patients with early breast cancer. We know the indication, contraindication for breast conserving surgery and for mastectomy. Here we will talk about the indications of adjuvant chemotherapy in early breast cancer. hormonal receptor positive, which are luminal cells or luminal subtypes A and B, they should go for hormonal therapy, but we know that the hormonal therapy will add it to the patient after the systemic therapy if the patient needs systemic therapy. What are indications of systemic therapy by chemotherapy in a patient with early breast cancer? If the patient has high-grade breast cancer, what I mean poorly differentiated, grade 3, the size of the tumor more than or equal 2 centimeters in size, if there is any involvement of the lymph nodes, or the patient having 21 gene recurrence score. All of these are indications of adjuvant chemotherapy in patients who has luminal cell types, which is hormonal receptor positive. For a patient who is having basoluminal cells or basoluminal subtypes, they usually will need trastuzumab, and all patients with 1 centimeter and more in size, they indicate also giving them chemotherapy regimen. And you will add trastuzumab with the chemotherapy regimen at the same time, as we mentioned in the general approach for the early breast cancer patient. For a patient who are triple negative, actually you cannot give them anything non-hormonal, no trastuzumab for them. So those patients, they will go for chemotherapy if their tumor more than 0.5 centimeter. So I think most of the patients who they have tumor with triple negative, they will go for, most likely will go for chemotherapy. What are indications of radiation therapy in early breast cancer? So we talk about the indication of chemotherapy, we talked about types of surgery, and here we will talk about the indications of radiation therapy in early breast cancer patient. As we know, the radiation therapy is external beam radiation, which will go to the breast. Post-breast conserving surgery patients, all patients who they have breast conserving surgery, whatever the type of the tumor, whether it is early breast cancer or DCIS, those patients will go for radiation therapy. Post-mastectomy patients have specific indications. Involved deep margin, or we have 4 lymph nodes or more positive for breast cancer. Mastectomy versus lumpectomy. Patients with early breast cancer prefer lumpectomy, but she has large tumor in relation to her breast. So if I have a patient that she has relatively small tumor, 3 centimeter for example, and the patient has small breast and she doesn't want mastectomy, is there any solution? Yes, I can give this patient new adjuvant chemotherapy, which is a chemotherapy we are giving it pre-op, and for operable breast cancer, because new adjuvant chemotherapy is indicated for patients who they have locally advanced breast cancer or inflammatory breast cancer. But here we can say new adjuvant chemotherapy for operable breast cancer. It actually increases the frequency of PCS by 15%. If you have 200 patients and you put each 100 in an arm, and one arm you treat them with new adjuvant chemotherapy, you will have 15% more of PCS in the arm of who are receiving chemotherapy, new adjuvant. Recommended in patient with HER2 positive. and triple negative, because anyway those patients, they will go for adjuvant chemotherapy, so there is no harm to give it to them pre-op. The problem is the problem of that one meta-analysis, it shows that it increases the risk of local recurrence by 8%. There is no difference in survival rate or distant free survival between new adjuvant and adjuvant group, and can be used as a bridge for surgery in pregnant lady in second and third trimester. You can give her new adjuvant chemotherapy till she deliver, and you can take her for OR. This is one of the approach for pregnant ladies. The benefit of the new adjuvant chemotherapy for patients who are hormone receptor positive is not clear. And those comes from the early breast cancer trialist collaborative group meta-analysis. Now we will talk about locally advanced breast cancer and inflammatory breast cancer. Again, this is the timeline. Here the timeline is different. We'll start with systemic therapy, which is new adjuvant chemotherapy plus trastuzumab if the patient is HER2 positive, surgery, and then radiation. Surgery shouldn't be less than mastectomy, especially for inflammatory breast cancer patients. So most of patients, if not all of them, if they get surgery after new adjuvant chemotherapy for locally advanced breast cancer and inflammatory breast cancer, they should have mastectomy, not breast conserving surgery. As we said, trastuzumab, we can give it to all patients who they have HER2 positive cancer during giving new adjuvant systemic therapy and hormonal therapy after surgery. What about the lymph node evaluation in such patient? We will talk about it later. Before we talk about the approach of the lymph nodes in such patient, we must go through the types of new adjuvant systemic therapy. We have new adjuvant chemotherapy regimen, and HER2 positive trastuzumab should be added to the regimen, as we said in their timeline, and hormonal therapy should be given after surgery for 5 years. Some of the patients who present with locally advanced breast cancer, if you give them new adjuvant chemotherapy, they will have complete clinical response, and you will not find the tumor after the new adjuvant chemotherapy. Such cases, before I start new adjuvant chemotherapy in all patients, whether they are early or locally advanced, I have to do for them localization. The second question, shall we do for them surgery if there is no more lump after new adjuvant chemotherapy or not? What is the limit of surgery? Shall we take the whole breast out? Shall we take only the lump, or what shall we do? The first question answer. Where is the tumor? So, to not miss the tumor, you have several types of localization technique. You will do it pre-new adjuvant start. You can put clip in the center of the tumor, or tattoo on the skin, or you can localize it by radiology, and you will fix a point, for example the nipple, and you say the tumor is 3 centimeter far and 5 centimeter depth, and this is the area where I will take the biopsy. from if I cannot find the tumor anymore. All patients who they receive neoadjuvant chemotherapy and their tumor completely regressed, they should go for surgery. Why shall we do for them surgery while they don't have any more tumor? Because very high recurrence rate. That's why. What is the limit of the surgery? In the patient who underwent neoadjuvant chemotherapy for locally advanced or inflammatory breast cancer, they should undergo mastectomy. For the patient with early breast cancer, it depends on the type of pathological. What do we mean by types of response after neoadjuvant chemotherapy for patients who they have early breast cancer and they have complete clinical response in their breast? For example, I have this patient. She has a lump in this area, and we put a clip here. After neoadjuvant chemotherapy, the mass, after the neoadjuvant chemotherapy, the mass has completely responded to the neoadjuvant chemotherapy, and she came to me without mass, and I have a clip here. I have to take 2 centimeter biopsy, 2 centimeter biopsy, open biopsy, and send it to histopathology. There are 2 types of response. The first is concentric response, like lollipop. Like if you have a candy and you keep it in your mouth for a long time, so all of the margins of the candy will regress in the same way. So it will be like this, and it will regress like that. So if the margins are free, there is no need for mastectomy. Just you will do for her, you have done for her breast conserving surgery by your biopsy. If it is completely gone, complete response, then this patient should go for radiation only. The other type of response, which is this type of response, actually we call it pathological response. Types of pathological response. So we have complete pathological response, like this patient, which we send her to radiation. We have partial pathological response, either concentric or honeycomb. If it is honeycomb, that means there are resistant cells here, resistant tumor cell to chemotherapy. So you have some cells here still, and those patients, they require the same pre-neoadjuvant therapy plan. If you plan them for mastectomy, do it for the mastectomy. So these are types of response after neoadjuvant chemotherapy for early breast cancer. What about lymph node management in neoadjuvant chemotherapy patients? The protocol which we will talk about is applicable for all patients who receive neoadjuvant chemotherapy except for the inflammatory breast cancer patients. Those patients should go for axillary lymph node dissection. Straightforward. For patients who their lymph nodes are positive pre-neoadjuvant chemotherapy, you can do for them straightforward axillary dissection, post-neoadjuvant chemotherapy. Or there is a new technique which we call it targeted lymph node dissection. And this technique actually consists of putting a clip on the positive lymph node which we detected pre-neoadjuvant chemotherapy. And after the neoadjuvant chemotherapy, you will do for her sentinel lymph node biopsy. You will take the sentinel lymph node biopsy, and also you will take this lymph node with you, and you will send both for histopathology. If both are negative, no need for axillary dissection. If they are positive, or any of them is positive, you can go for axillary dissection for them. The patients who they have negative lymph node pre-neoadjuvant chemotherapy, some people they will do for them sentinel lymph node biopsy pre-neoadjuvant chemotherapy, and this is actually will delay the neoadjuvant chemotherapy, and some centers until now they are still doing it. Or they will do sentinel lymph node biopsy post neoadjuvant chemotherapy. Those people who are doing it pre, they have some studies which shows that the neoadjuvant chemotherapy will affect on the lymphatic system and lymphatic vessels, and this will not give them the right lymph node, the right sentinel lymph node. So maybe they will miss the lymph node. For those who are doing it post, they believe that it will not be affected too much by the neoadjuvant chemotherapy regarding the lymphatic vessels. So as we said, all patients with inflammatory breast cancer, they should undergo axillary lymph node dissection. Metastatic breast diseases, they should go only for palliative systemic therapy. What is the role of surgery in local disease in the breast and axilla, and the role of surgery in distant metastasis? We will answer this here. Stage 4 disease, unlikely to be cured by any means. Palliative surgery can prevent local complications like fungating mass with offensive smell and bleeding, and other local complications. In some studies, they found that those patients who underwent toilet mastectomy or mastectomy for some local complications like bleeding, their survival is a little bit good on some retrospective studies. But this is maybe due to selection bias and confounding variables. The surgery of metastasis itself is still diagnostic. So I cannot go and do for a patient partial hepatectomy because he has metastatic breast disease here, for example. Occult breast cancer. Occult breast cancer means that I have axillary lymph node while I cannot find any primary tumor. It represents actually 1% of the breast cancer. The patient should have all routine radiological investigations, including ultrasound and mammogram. If you cannot detect anything, you can do for them MRI, or you can go further by PET scan and other types of radiology. There are new radiological assessment methods. If you cannot find anything in the breast as a primary, then they should go through this protocol, which is in the Anderson protocol. You will give the patient neoadjuvant systemic therapy, and then the patient will go for modified radical mastectomy, or we will give them neoadjuvant systemic therapy, then breast conserving management. That means you will not take her breast out, and mean you will not do for her mastectomy, and then you will go for whole breast radiation. Breast cancer in pregnant ladies, we can divide them according to the trimester. The first trimester pregnant lady who they have early breast cancer, they can go for modified radical mastectomy and wait till the second trimester. Then you can start her on chemotherapy, then radiation if indicated, with trastuzumab and hormonal therapy post delivery if indicated. If they have locally advanced or inflammatory breast cancer, those patients usually we advise them for abortion to give her the best chance of chemotherapy. And second trimester, if they have early breast cancer, we can do for them mastectomy or breast conserving surgery. You can also start them with the new adjuvant chemotherapy while they are in their second trimester, and after delivery you can do surgery for them. Then they can take radiation and complete their treatment. The patient who have locally advanced or inflammatory breast cancer and they are in the second trimester, you can start them on the new adjuvant chemotherapy. The third trimester pregnant ladies, as non-pregnant lady, you can treat them like non-pregnant lady. These are some important, and really I picked them from MCQ's box, and they are really important MCQs. It will give you good orientation. You can go through them and you can try to solve them. You can send the answer in the reply. We can discuss it in the reply also. Thank you very much.